Nomfula, nomfula.
Hey, nomfula,
Nomfula, nomfula.
hey, nomfula. Uyaluma sithanda nesilale emathungeni. Uyaluma sithanda nesilale emathungeni.
Mining has been a crucial industry in South Africa for over 150 years. Globally, the country is known as a world leader in mining and is famous for its abundance in mineral resources, accounting for a significant proportion of the world's production and reserves. The mining industry has played a defining role in the course of South Africa's history in the last 1.5 centuries. The Great Mining Revolution turned the country's economic fortunes from a rudimentary status to a prosperous one that catapulted her into the middle-income status within a continent dominated by low-income economies. As the mining industry grew, more workers were required. Some came by choice, others forced by socioeconomic circumstances.
I was supposed to pay the police officer, and then I failed. I did not perform, I did not obtain better marks in my Cambridge examination. So I did not have money due to the fact that I was from a very, very poor family. So we've got no father. We grew up with only our mom. So there was no way to get money to go and upgrade my symbols. So then I decided to flee to come to South African mines, so as to get some money and come back home and go back to school and do better.
A majority were recruited from deep rural areas of South Africa and countries such as Lesotho, Swaziland, and Mozambique.
We used to see Tepa around, people going there, going up to the mines, but it was not my intention to go and work in the mines. I used to see people with traveling bags, getting to see trains and whatsoever, get packed when they come back home with some loads. Oh, so I said, hey, maybe I can make a living and then get money and then go back to school. That was my intention.
However, this period of economic success has come with its fair share of downsides.
I could simply summarize by saying South Africa benefited from gold in the 80s, but we are paying dearly now.
By its very nature, mining activity is labor-intensive and often disruptive to the entire ecosystem. Most importantly, mining also poses health challenges to a sizable portion of the citizenry, especially within the mining families and communities.
Specifically to health, it's one of the dynamics in the mines because you're dealing with people. And of late, in the last, 10, maybe 15 years, there's been much more appreciation of health in the mining industry. And keeping people healthy, basically, has been a huge challenge.
One of the most devastating health challenges of the mining industry, particularly the gold mines, is the high rate of tuberculosis infections among its mine workers.
Tuberculosis is a bacterial infection that is transmitted through air. So if someone has TB and they cough around you, then you're exposed to TB. The majority of people who live in Africa have been exposed to TB. But those who have been infected, the TB is dormant in their lungs, and there's some condition that could activate TB.
According to the 2012 World Bank report, mine workers account for the largest portion of TB infection rates in South Africa.
Now, when you look at the key population, key people who are affected by TB, one of those key populations are in the mines. People who are working in the mines are 7 times more likely to have TB than the rest of the population.
The silica dust, which is attributed to the high rate of lung diseases among mine workers, has been a problem and remains a thorn in the flesh within the mining industry.
The dust that comes secondary to the mining activity, which then gets breathed in. and over time causes lung diseases, ranging from just a thing called silicosis, where the silica dust is embedded in the lung.
The mine workers are exposed to a lot of dust, and the dust inflames their lungs, and that activates the TB bacteria.
Sometimes when the mine a rock falls, it will fill us with a white dust that when you get out of there, you will look as if you've been spinning in a cement. And then later, I started coughing while I was there at the mines.
Gold mines produce more silica dust than any other mine, any other mineral. So more people from the gold mines are suffering from TB than people from other mines.
With over 2 million people globally dying annually from TB, according to the World Health Organization, it is also the leading cause of death among HIV-positive people in the world.
HIV testing in TB patients, WHO policy is that all TB patients should be afforded a HIV test. And this is because we know that in our region, the relationship between the co-infection is very, very high.
TB, HIV are the two that goes together. If you don't manage HIV correctly, TB will get you. So it's the way we explain to the employees to ensure that they understand the benefits they will have for us to put them in the HIV program. And once you put them in the HIV program, we prevent further TB diseases in the future.
40% of all people who are HIV positive who die on the African continent, they are killed by TB, 40% on average. But in my country, in South Africa, and many other high burden countries, it's actually 80%. 80% of all HIV/AIDS deaths are actually attributable to TB.
One of the contributing factors to the high rate of HIV among the South African mine workers can be explained from the fact that most of these mine workers are migrants from the neighboring SADC countries. Most of the migrant mine workers usually leave their spouses back in their home countries and have to work many months before returning home.
You see, living in the mine without a wife, it's a difficult. It was a difficult task. We used to go to what we call the mkukus over the weekends and see the ladies and all that, even in the locations. As I've quoted Pegastar, it was the first time for me to see Pegastar. And those people from Pegastar were very much attractive. They are attracted because they know that we've got money. Since we've got money, we have to pay them.
He's thinking for her kids so that they could get something to eat.
If you have got silica dust from working in a mine, your chances increase by 600%. If you have got both HIV and silicosis at the same time from the mines, and many mine workers have got both. If you have got both, your chance of getting TB is 1,800%. So you are very, very vulnerable.
Many employees still opt to live outside the periphery. This has, however, not been the best solution due to the conditions in some of these outside accommodations, like in the shacks. Where there is no sanitation and is densely populated, migrant mine workers encounter yet another form of frustration.
Mine workers live in overcrowded conditions and also work in very overcrowded space. And as a result of that, if one person is infected, they can spread the infection to other people.
We have actually started a project to reduce the number of occupancies per room. We are currently sitting at 1.1 per room in Sibanye Gold, which was a huge achievement with a lot of money that was spent to try and decongest the rooms.
So we've put what they call your ultraviolet lights. Ultraviolet lights are the lights that helps to kill the bacteria in a circulation in open areas. So that in places, in Harmony, we've put those ultraviolet lights in common rooms. We've put those ultraviolet lights in places like your kitchens, places, as long as we believe that there is overcrowding to a certain extent.
Most of the citizens in the labor-sending communities have bore the brunt of dealing with the diseases that their citizens who work in the mines acquire from South African mines.
We are victims and villains at the same time. We are victims because we have got a lot of TB. We are villains because we are spreading it all over. We are sharing it with you via the mine workers you send to South Africa. So for that reason, we thought we need to take the lead.
Regardless of location, whether in South Africa or any other SADC country, TB infections and its spread does not discriminate.
No one country within SADC must try to fight TB alone. We've got to work together. As I'm saying, because the gold was mined in South Africa, but the mine workers were coming from all over the region. But also, unlike HIV and AIDS, with HIV and AIDS, a person can stand up and say, I don't want to get HIV positive. I don't want to be HIV positive. You know more or less, you more or less know what to do to protect yourself. With TB, it's difficult. There's no one human being who can stand up and say, I can't get TB. Because as long as you continue breathing, you are likely to get it. As long as we have got people crossing the borders to and fro, it's likely to be spread. So you have got to work together as a whole region, not as an individual country.
TB-infected mine workers pose a transmission risk to their colleagues, families, and communities close to the mines.
So we have a silent killer here in South Africa. Tuberculosis is a serious epidemic that affects not only South Africa, but the neighboring countries as well. And it's worse in the mining sector because miners live in overcrowded conditions. They work underground where there's dust. There's an underlying HIV disease, and they come from different parts of South Africa and different countries. So when they get sick and they don't get the right treatment, and they go back to where their villages or they go back to their country, sometimes they don't get the right treatment, and therefore they are spreading the disease to their family members and to the communities where they come from.
The people of Basotho have been working in the mines in South Africa for a very, very, very long time. But the number of the Basotho who are working in the mines has gradually been it's reducing gradually. But we don't see the cases of TB reducing. We don't have capacity to diagnose silicosis, and we are probably missing a lot of cases with silicosis, which is a risk to TB.
What makes me sad is that we now know that TB is the biggest killer of all infectious diseases. But people, even health authorities, they don't seem to know or they don't seem to care, because TB is a silent, slow killer. So that saddens me, because globally it affects 10 million people and kill 1.8 million of them. In my own country, it kills 40,000 people annually. I've just checked that in 60% of African countries, TB is in the top 5 of all killers.
It's important for SADC to address the issue of TB in the mines, because a lot of people have been working in South Africa since time immemorial, and in the mines they contracted this disease, which then ends up spreading even to the members of their families. So it is important that it is addressed and people are assisted, and those who need to be taken to hospital for medication to be assisted.
Finding a solution to tuberculosis in the mining sector has not been easy. It has taken more than 100 years because it requires the involvement of different sectors. Ministries of Mines and Minerals as the parent ministries, Ministries of Health because TB is a disease, Ministries of Labor because these are workers, trade unions or labor unions that represents the interest of workers, private companies because mining is privately led in Southern Africa, association of ex-mine workers, these are people who have worked in the mines that are now suffering the consequences of mining. Sometimes these people fight each other.
and therefore trying to bring them all together to identify key actions that are required to tackle this problem has been the biggest challenge.
It's been very difficult trying to build relationships, trying to build consensus, trying to find middle ground, trying to negotiate, and of course, you win some, you lose some. But I think on the whole, we have come very far.
When I listened a little bit to the discussion on the regional ministerial meeting in March, I was a little bit stunned because when I had individual conversations with representatives from mining companies and so on and so forth, it sounded to me like each and every one said, oh yeah, this is a great idea, harmonizing our approaches, and if you adopt our approach, which we have developed, then that will be perfect and will please everybody. And the next one said the same thing. So I think that's not how it works. And I think Mark Dybel very accurately said in that meeting that actually the affair and the task that we have is not a difficult one. It's not a difficult one at all, technically speaking. But I think in order to achieve that, we all need to give up something. Be that the mining companies, we cannot just carry on having our own data collection, our own diagnostic systems, our own treatment systems, and expect that everybody will else adopt to ours. And in terms of countries, well, likewise, if we all keep to our own health information systems and don't share them, we'll also not get anywhere. So I think it's about giving up a little bit, but it's also about recognizing each other and recognizing the efforts and what has been done by others and how we can come to a common approach. And I think that's why we're here.
The government of South Africa requested World Bank for support, and the first thing we did was to generate evidence to show the magnitude of the problem, and then use that information to mobilize ministers of health, ministers of minerals, other stakeholders, and collectively a recommendation was made that this was so important that should be discussed at the SADC Heads of State meeting, and the Heads of State declared TB as a regional emergency, and that unlocked significant resources that now we are using to tackle the problem.
Congratulations everyone, this is a great moment for us in the country.
And we're also hoping that the additional $30 million that we will be putting into this regional program over the next few years will effectively be catalytic in terms of both raising the profile of the issue, delivering more services on the ground, pushing the coordination, and we hope leveraging additional money from others.
The World Bank donated $30 million. They are helping us in these coordination efforts. They are the ones who bring us together. They are the ones who are compiling the common database for all these other countries. So they are playing a very, very important role. They are the technical advisors. They give us the technical knowledge, the logistics, the donations. And as I'm saying, even the logistics to put these one-stop centers and link them, the World Bank is helping to do. They are working together with the Global Fund to help us do that.
And I think the World Bank's role in that also been, apart from being a funding partner to this, has also had a significant degree of vision in pulling the various partners together. But as we all know, nothing happens without funding. And I think that particular contribution by the World Bank, as well as the persistence that they've had and their facilitatory role across the different countries, has been instrumental in making this a reality today.
We have worked together with the Global Fund and the World Bank to try and coordinate our activities to develop a common database of all the mine workers in the region who have got TB, to develop common treatment protocols, but also to decide on referral patterns around.
One of the key achievements of this initiative has been the harmonization of TB treatment protocols across Southern Africa. What this means is that a mine worker from one country can cross over to the next country and have the same treatment. No other region in the world has been able to achieve this.
This process will remember that there has been a lot of lobbying, particularly from the Ministry of or Department of Health in South Africa. And would like to pay tribute to Dr. Aaron Mtswaledi and the ex-Minister for Health of the Kingdom of Swaziland, Mr. Benedict Xaba, who, through their leadership, have seen this build up to this exercise in terms of ensuring that ex-miners do get to be attended to with regard to their health, but also with regard to those who got TB in the mines and were never compensated.
We owe you money. Because of the prevalence of TB in the mines, yeah, we owe you money. Because of the prevalence of TB in the mines, South Africa has got a compensation mechanism, which is called CCOD, Compensation Commissioner for Occupational Disease. Unfortunately, this structure some 15 years back collapsed. People who get TB from South African mines were not being compensated, not at all. And the money to compensate them must come from the mining houses, not from government. But we have now woken up, we have rejuvenated the structure, we have chosen a new commissioner who is an occupational health specialist today.
So as Commissioner for Compensation in the South African Department of Health, the approach we had to take was that we have some very rigorous criteria for what is a compensable illness. These are tuberculosis, silicosis, coal miners, coal workers, pneumoconiosis, asbestosis, etc. So these are various disease affects the hearts and lungs of mine workers. So I'm very much working in that space.
Mine workers, especially black mine workers, have to be compensated better. Around 1994, at least there was a change of legislation. Initially, a mine worker, regardless of the levels of TB, he will be compensated 2,000 rand, regardless. Now we have been able to fight until now. We have got your first degree and second degree, and the compensation is better.
People feel that there is hope after all these years of not getting what they've been working for in all these years.
The conditions under which they live is beyond explanation. There's extreme poverty, malnutrition, there's a lack of family planning, and also what we found is, especially with the person that has been paid a first degree, that there's no financial information to help them to manage that. So just when the money comes into the bank account a few months later, the money has disappeared. They've used it and it doesn't benefit the family. So I think that there should be an extension to our tracking and tracing program to provide financial education so that the money is better managed in order to benefit the family as a whole.
The regional grant for TB in the mining sector was signed in December last year and came into effect in January of 2016. The TIMS PMO, which falls under WHC, has spent the last 6 months with very detailed planning. A lot of this time over the last 6 months was spent on SR selection, being able to find the best and most appropriate implementation partners that follow along on this journey over the next 24 months. We also spent a lot of time selecting country coordinators who will be hosted at the national TB control programs over the grant period. These will be our hands and feet in each country to be able to provide an interface between the PR and country stakeholders.
I feel that the launch of this grant is going to resolve thousands of problems of miners that are seeking health assistance in the communities.
The goal of TIMS grant is to contribute to the reduction of TB in the mine in the 10 countries. Now, the data on key population on the miners is lacking. The tools in the countries do not segregate data by key population.
We are pleased to report that as of today, the Logistics Coordinating Center will be operational here at my boardroom, whilst we are finding a permanent place for later, to ensure that we deliver on the promise of trying to get a database going for all ex-mine workers. We'll try and include current mine workers.
In this database, the current database that the MPOD through the Department of Health, we have about 103 as those that we can say they can be traced, and out of those, only 64 were paid.
Globally, in 2014, there is now a new strategy and new set of targets to end TB by 2035. What it means is that we have to make progress at a much higher pace than what we have done in the past. In the past, the incidence of TB has been declining at a rate of less than 2% per annum. This has to change now. We have to be on a trajectory of decline of at least 10% per annum in order to reach the 2035 targets. In order to do that, it is no longer possible just to do business as usual and care for the general population, provide TB care and wait for people to come. We have to be more proactive. We have to be more proactive in providing care to people in a more active way, looking for cases.
In order for the project to move smoothly, there's a need to engage NTP managers in each and every step, especially when it comes to planning for activities and ensuring that also the NTP managers help them in linking them to other relevant stakeholders at home.
We've had an excellent turnout today. I'm sure we have about 100 community health workers sitting here and going through the training process. We've trained them and given them a lot of background information so that they will be able to, they are empowered to understand the processes at the NBOD, give people information that would basically restore confidence in our process. We've trained them on the way to register ex-mine workers to find out their circumstances and things like that. And besides the tracking and tracing, we want to link them to care programs beyond our tracking and tracing project.
It was a very good session today, the training, because it made us to know how are we going to trace these people. Yes, that was the most part, because in most of the times things like this have happened. Maybe that department which is arranging that training just come with pamphlets and then issue the pamphlets to the people and then go. But it didn't happen with the Department of Health. They have tried to explain the forms step by step to us. And they have also told us that they are going to give us support when we are working on the field, so that we must make sure that everything had happened the way it should be.
The process started with us physically tracking and tracing people in the districts with the highest burden of unpaid claims. So we contracted the Ex-Mine Workers Association in Swaziland, which then contracted field workers to go out and physically door-to-door trace people who are actually due compensation.
We've been working with World Bank from 2008 to date on issues of TB in the mines, and quite recently we started on tracking and tracing, which is more on registration of miners to come up with a database to assist miners to get their compensation. You will know for sure that there was about 2.5 billion rands that has been left unclaimed from the Medical Bureau for Occupational Diseases.
The medical examinations and claims management then takes place in partnership with Aurum, that helps to provide the health clinic, which you see behind me, is the health clinic which has come across the border. It has a chest x-ray, we have lung function facilities, we have a clinical evaluation facilities by nurses, and essentially that completes the medical examination part, which has to be undertaken every 2 years.
As you know, that there was a mobile clinic. We have the hope that we will get funding where we will build hospitals that will be specifically for the examination of ex-miners and current mine workers, so that we avoid the dilly-dallying and the going up and down, being thrown from pillar to post of the ex-miners, such that they lose interest and thus forfeiting their benefits, and their health is at stake.
The other very important development is that in South Africa, we've put up what we call one-stop center, where an ex-mine worker will go for examination to see if they've developed a silicosis or TB or even cancer or any one of the occupational lung diseases that develop over a long period of time, even after people have left the mines. We've got those one-stop centers. Once we examine a mine worker and get diagnosed, they get help to get compensation, but they also get rehabilitated. And I'm happy to announce that since that period, 11 other centers are going to be built with money from Global Fund in the SADC region of South Africa. That includes Lesotho, Botswana, Swaziland and Mozambique. From there, the next group of countries is going to be Namibia, Zambia, Zimbabwe and Malawi.
The Aurum Institute has been involved with mine workers and mine worker TB, HIV and silicosis since 1998, and we've long had an interest in seeing that mine workers can get something of the benefits they're entitled to when they come out of a long career in the industry. But we've been particularly concerned that getting that benefit medical examination to where they live is something that has not been traditionally done. Mine workers were expected to come to Johannesburg and seek their examination and then hopefully expect some compensation.
I am humbled to be here today. What I've seen today here, it's one of a kind. I've seen all sorts of people from all walks of life, coming from all regions from the Kingdom of Swaziland. And it is humbling indeed that finally our partners in SADC have come here, and I've spoken to quite a number of the different people are being tested, other people are being recorded onto the computer system, others are going through the x-rays, and others now, as I can see, are queuing with the Swazi Bank to open their various accounts so that their benefits are deposited into the Swazi Bank accounts. This is very humbling that you can put everything together and a one-stop shop where you have doctors, nurses, technicians, and the clients that we serve. Instead of them going from hospital, knocking at this door, everything is here together today. And we really appreciate and thank you to the World Bank for making this possible.
In the past, when this service was given for whites only, they will come to Johannesburg in a place called Braamfontein, where they'll get all this benefit examination, classified, and fill forms in for compensation. But when the black people were not even considered, once you start considering them, you can't expect them to travel from far rural areas to come to Johannesburg. So people don't have to travel. The services must go to them, because otherwise many of them won't find their way back into South Africa, either because of ill health or because of old age, or because of their financial circumstances.
I only have money to go to Johannesburg. If these people were not here, I couldn't be able to go to Johannesburg, because at the moment I haven't got money. I left mine in 2010. So until today I'm not working, and I haven't got any income. So that's why I came here to be tested.
What we are doing right now, we are examining ex-mine workers. We're doing lung function with a spirometry. So basically we do 3 lung function tests, and then from those 3 lung function tests, it determines the degree in which the patient's lungs are damaged.
Well, I also forgot to add that apart from Global Fund and the World Bank and the World Organization, we are also working with the International Office on Migration, because mine workers migrate all over. So one of the lessons we have learned is cross-border clinics. We have identified the routes through which these mine workers travel, and we need to put up cross-border clinics where they are getting services.
There's a whole range of services that as the department now we need to put in and complement what the MPOD is doing. Integration is important. Working with other partners in a public-private partnership can yield good results in terms of making sure that the continuum of care for these people for TB, HIV and development programs are actually effective in the communities.
It's the responsibility of the mine to see that their employees are healthy. So we test them so that they can get their treatment as early as possible so that they can continue with their work and go back to the work.
The NTB strategy of the World Health Organization, they have adopted the 90-90-90, as you know, that in each of our country, we must reach 90% of all the people who we think have got TB. Meaning those vulnerable population have shown children, people in the mines, people living with HIV, AIDS, diabetics, etc. Make sure that 90% of them know their status, make sure that you put them on treatment, and that we have got 90% success rate. This is the NTB strategy.
So the dashboard contains key indicators for the 4 key operational areas of the grant. So programmatic, financial, management, as well as procurement and supply management. So keeping track of these indicators will tell us where the problem is as it develops, not after the fact. So identifying the problems as they arise allows for management to take quick action, quick corrective action, and the right corrective action so that implementation is on track.
The difficulties we've had is logistics. I mean, you can see we're in an open field. We we don't have a fixed facility. There's some issues with toilets. We've had to, lucky the weather has held out in terms of this process. So the difficulties have been really in terms of also customs procedures to get equipment across the border and also get them back in. But otherwise people have been very patient and the numbers are coming in.
In the early phases, of course, things go slowly, but once people get to know what's happening and see that it's starting to work and people start getting paid compensation, they see that people actually care about them and look and have the facility to check lung functions and do x-rays and that type of thing, then it'll really get momentum. So I can really see that it has gained huge momentum in the last 2 years, but there's a long way to go.
I'm happy today that things are promising. As I've seen many doctors coming here, and the mobile clinic is here, and I've tested my health.
I believe that we will not only defeat TB, but we are committing ourselves to extinguish TB. TB, we are coming to you.